Mind your health.
You got to mind your health.
Mind your health.
Treat yourself. You got to mind your health.
Welcome back to another podcast of Mind Your Health. Today we have Dr. Ryan Rosenblatt with us, and we're going to talk about GLP-1. I know all the brouhaha, all the ins and outs of GLPs. Ryan, good morning.
Good morning.
Ryan, good morning. I look at you. You guys are like, yeah, this is what we talk about, isn't it? Let me bring this in a little bit so I can get all my questions answered.
Shoot.
More and more I hear about GLP-1s. I would like just a primer about what GLP-1s are and why they are one of the most talked about pharmaceuticals in today's world.
Absolutely. So it is very much a hot topic. They've been around a little bit longer than most people realize. I'd say 10 years or so was the first one released. But the more recent and modern ones have such a potent ability to help with blood sugar and weight loss that it's kind of taken the world by storm. They were originally invented to treat type 2 diabetes.
Correct. Okay.
And during the trials of those, just getting them approved, they did subsets where they found great benefits like cardiovascular prevention, extreme weight loss, like in the over 20% in some cases of body weight. They've even seen some kidney protection for kidney disease. And that really all harkens back to diabetes being such a kind of a wreck to the system, where they're finding out more and more that the longer you're a diabetic, the more it progresses, but it also affects different systems at different rates. And there's a lot of comorbidities with diabetes. And so having more people have access to these medicines has really hopefully been able to let people prevent diabetes from progressing and to help reverse some of the terrible, comorbidities of diabetes. And on the flip side, there's a lot of people using it for pure weight loss.
Right.
So, the drug itself doesn't really know, go make this person skinny or go make this person have no diabetes. But so the poison's in the dose, so to speak. And so they do have to be guided by a doctor, and you have to be monitored. It's not something I would recommend people buy from a neighbor and start using, which I've heard horror stories of and so on. So certainly a medicine first.
Okay, it is a medicine. What does GLP-1 mean?
So GLP stands for glucagon-like peptide.
Okay.
And these medicines are receptor agonists.
Okay.
So a receptor is a part of a cell that the most common use is the lock and key.
Yep.
So that lock and key model is very useful to visualize what it is. So the receptor agonist would be the key. It finds the lock on the cell, and when it meets up, it turns something on. It opens a door. It can make your DNA and your protein synthesis kick on to have different overall changes to your body. So there's a bunch of receptors and there's a bunch of agonists in the body that the body makes. GLP is an endogenous peptide that your body makes already.
Right.
Scientists at these companies have found a way to almost copy that endogenous GLP and create peptides that are obviously man-made, and they're given exogenously through injection.
Okay.
And so they kind of follow the same pathway as the one your body already makes, but it actually works better and lasts longer than regular GLP.
So what exactly is that GLP-1 doing? Is it slowing down what? Speeding up what?
So I don't know how in-depth you want me to get, but basically this diabetes and overall sugar regulation is a multifaceted systems. So most importantly, the way the GLP-1s work is they are slowing gastric motility, so you stay full longer.
Okay.
Your stomach doesn't empty into your small intestine. It also signals to the brain in the hypothalamus in receptors that are GLP receptors in the hypothalamus, and it tells your brain that you are getting full, and it slows down your hunger.
So I work with eating disorders. Ghrelin and leptin are two hormones. And for people who have eating disorders who have used these GLP-1s, what they say anecdotally now is it's the first time in their life they have not had food noise.
I've heard that anecdotally
Right?
as well. Yeah, and it is a potent thing. And I think that's part of why they've been so successful, is because it has a mental aspect. All the other diabetic medicines, as far as we know, don't really have that signaling to the brain.
Well, additionally, because I work with folks who have substance abuse issues, it's the same thing. For some reason, people are saying it's the first time I haven't crave that second glass of wine. I'm able to have that glass of wine and say, that was delicious. And so, again, these are anecdotal things, but we're seeing physicians using the GLP-1s even for substance use.
Yes, I'm aware that there's studies ongoing regarding that. I don't know that they've been conclusive, but like we
Oh,
said,
they haven't been.
there's definitely stories, and people are all encompassing. So just because you're diabetic and you take this medicine doesn't mean you don't also have a substance abuse issue that could also be helped from taking this medicine.
Actually, good point.
Yeah. So, I mean, like I said at the beginning, it doesn't know why it's being injected, and it certainly just works where it can. And
Correct.
There's a few more places, in fact. So, and one of the most unique things about GLP is that it tells your pancreas beta cells to release insulin in a glucose-dependent manner. So it does it when you have food in your system or sugar in your system, which is one of those things that makes this very special molecule. And it also stops your alpha cells from releasing glucagon, which is what tells your liver to make more sugar when you're fasting or overnight. Your liver uses glucagon signaling to increase the sugar in your system. But diabetics, that's either run off the rails and is not working properly, so you are constantly having more sugar be dumped in your system from your liver and basically your fat cells as well.
Okay.
So it's essentially kind of a way to get everything back on track. And it can help regulate essentially all the different systems that affect blood sugar in your body.
Additionally, it helps from a lifestyle point of view. If I don't have food noise, it's going to be easier for me to balance and maintain what I eat.
I think that's fair. I mean, it's certainly, we tell a lot of people that, this is not the magic bullet. You need to include diet and exercise to go along with it, especially if you do end up losing a lot of weight. You need to maintain that, and you may need to change the way you consume food or consume nutrients because your body changes quite
Exactly. And now we've talked kind of about the rainbows and butterflies of GLP-1, but there's also sort of a dark side, if you will. Can you share a little bit about that, David? That's something that you feel strongly about.
Yes. So I don't know if I'd use the words dark side, but,
sounded dramatic.
Well, what we've talked about is, all right, so now that I've lost the weight, I've lost 30, 40, 50 pounds, now what? It's not, I don't know if it's realistic is the right word. It's probably not a good long-term health benefit to be on an injection the rest of your life. So how do you balance that? Because if I don't want to stop these injections, and having lost 40, I don't want to put on 60.
No,
so much of it is here. How are people dealing with long term?
So one of the limitations of the GLPs is that it doesn't change insulin sensitivity in the muscles. So essentially,
what does that mean?
So you can have, and this is a part of the bigger picture with diabetics, but the receptors for insulin are also all over your body, and that's how cells uptake the sugar that's in your bloodstream.
Okay.
The ones that need to utilize the most sugar are your muscles. And in diabetics and people whose blood sugar is out of control, even though they might have insulin floating around trying to tell their muscles to uptake all this sugar, it just doesn't work as well. It's like your key only fits halfway in the door.
Okay.
And so the muscles are what would burn the most sugar. And insulin sensitivity is essentially kind of a buzz thing, or it's a technical term where essentially that's how well your insulin works on your cells around the body. And if it's GLP-1 doesn't change that.
Okay.
So essentially, if we could find a medicine that could increase insulin sensitivity, that would maybe be the long-term approach. And there are medicines like pioglitazone that has been around a long time that is in a class of medicine called the TZDs. I'm not going to try to pronounce that long one on here. But essentially, that's an old medicine that has also some contraindications. That's the only one we have that helps with insulin sensitivity. And so there have been some studies where they're using them in conjunction to try to improve insulin sensitivity, which I think is a way to have longer term maintenance of your weight.
So I think from a lay point of view, I grew up with semaglutides. I guess it's semaglutide now. I don't know which one it is, but with a semaglutide, and then there's the Wegovys, there's Trepizide.
Tirzepatide.
Yeah, but those are all a bit different too, correct?
Yes. So those are the drug names or the molecule names.
Yes.
Semaglutide or semaglutide is a pure GLP-1 receptor agonist. tirzepatide is a dual action. It has
Right.
GLP-1 receptor agonism and it has GIP receptor agonism.
This is, I think I've
And-
died and gone to heaven just so you know this.
So again, GIP is a long acronym. It's essentially another incretin, like what you were
Right.
saying, where it can help suppress glucagon release and it can increase beta cells releasing insulin in a glucose dependent way. So when you eat, so it's adding an extra so to speak, with those tirzepatide versus semaglutide, which results in a lot more weight loss. So high dose semaglutide, you get about 15% in the studies. High dose tirzepatide was over 22% weight reduction.
Now, we talked about this before. Many people are going to the internet. There's a lot of places that you can have these medicines compounded.
Mhm.
Number one, can you talk to us a little bit about that? And number two, what are the upsides or downsides or dangers or all of those good things?
So
I mean, we're talking Mind Your Health here.
So the products that we're talking about are all, originally made by a pharmaceutical company and patented and approved by the FDA. They became so popular for all these great reasons we're talking about that essentially the factories that make them for Novo Nordisk or Lilly and others
Sure.
couldn't keep up with demand. So they got put on what's called as the FDA shortage list. So that's a government issued list that basically says these medicines are in short supply and we deem them necessary for the public health. So we're going to allow compounding pharmacies to produce them for a limited amount of time and in a limited amount of ways. So what that did is it opened up the door for sterile compounding pharmacies. So compounding pharmacies that have sterile hoods and clean rooms that follow good manufacturing practices. The majority of them and the ones that I would say are reputable are ones that have inspections by the FDA, but they're not considered full on factories, so to speak. So that's called a 503B compounding pharmacy.
Okay.
And so those pharmacies picked up the pace and said, okay, we're going to be able to manufacture this or compound it. So they're taking raw materials, sterilizing it and putting in solution and selling it in vials, which is one of the biggest differences between the commercial products and what's available compounded. The commercial products come in fancy auto injectors, they're called.
Okay.
So they're easy to use. They're all self-contained. They deliver the exact dose. A vial of medicine is, if you've seen an insulin vial or a B12 shot vial, it's the same idea where you have to put a needle in the vial, draw up your dose, and then inject yourself in the skin. So that's where pharmacists have come in. We've tried to help guide people on, some people have never injected themselves with anything. So we're doing a lot of teaching to try to help them understand what to do, how to safely do it, how to be clean as possible. And then, like you said, another difference is how long does it last? And once you have it open, things like that are limitations that are different from the commercial products because they have more longer term stability studies, and they've been making it for a number of years.
So here we are, spring of 2025, and that the supply was not able to meet the demand. Well, now it is. So what I understand now is there will not be any more compounded, right? It will only be the brand name manufacturers. So what does that look like? I'm sure there's a pricing, obviously. But
So the commercial products, if you were a self-pay customer and you need to pay like the MSRP, like on a car, like a list price, something like Wegovy is around $1,400 a month. Something like Mounjaro is around $1,400 a month. So that's a lot of money. No, that's what the list price is, the manufactured suggested retail. Insurance, you would have a copay, and then the pharmacy would hopefully get reimbursed for that large difference. And so insurance coverage is another topic regarding this, but people have been paying for these compounds, which are about half the price.
Okay.
Essentially, that's what's going on, is they're about half the price. Part of that is because, it's a limited release type of deal. And part of it is because those auto injectors they're using are expensive and they're patented and all that kind of thing. And part of the shortage, we think, was the auto injector because Eli Lilly uses that same auto injector for multiple products, and those started to go on shortage too. It's like, well, there must be some cause and effect.
How do most physicians feel about GLP-1s?
Some are a little skeptical. Some are put it in the water. It just depends. it depends on what their patient population is and how many people they can benefit from it. I mean, there's obviously a lot of places to use it, and its place in therapy is certainly mainstay, especially for diabetics. It's become, first line or second line therapy for diabetic patients. So they're not shying away from it. It's considered intensive therapy for diabetics, so it's a good thing.
Type 2 diabetes?
Mhm.
Okay.
So you talked about this is not new technology. The drug is not new. It's 10 years old, but the weight loss and the really good things have only been, the last couple of years.
Right.
Do you see in a couple of years, 3 to 5 years, are we going to have a plethora of new products that are going to help people be, am I finally going to get down to 125 pounds?
I think that there's no stopping the revolution in basically research. I think that these companies are seeing how much demand there is and how potent these pathways are for the actual medicine from a scientific point of view. So certainly there'll be more research. I'm not aware of anything that's pending immediately, but it's certainly interesting how they took a diabetic drug and then they immediately marketed it for weight loss when they figured that out. So it's the same molecule, just some different doses. And again, now that shortage is ended, there's going to be pressure on these companies to lower their prices, I think. We've seen people, very much appreciating the lower prices from the compounds. They're used to getting it from either the local pharmacy. There's also some online pharmacies that are reputable that are using these compounded things.
Okay.
To the point, in fact, where one of the companies actually started releasing them in vials so that they could save the cost on the injector and they could have that more accessible. So that is out there. I don't know if they're going to continue that and maybe release that to pharmacies. That might be a way for them to drive down their costs, which they could share the saving with the pharmacies, which could then share that savings with the patient. I'm hopeful that's the case. But I will say I like the auto injectors. It's less to mess up, so to speak. We've had some errors where patients didn't understand what a milliliter is versus a milligram. Had to, teach them again how to do everything. And that's fine, and that's part of our job.
Sure.
But there is somewhat of an ease to just saying, this is my pen, I put it on my stomach or my leg, and I inject.
So it's kind of interesting because childhood and diabetes rates in the country historically have been going up and up and up. Now that these GLPs are becoming way more prevalent, it's going to be interesting to see what happens to those rates of diabetes, especially childhood diabetes.
I mean, it is a little not controversial, but they are used in people under 18. They are. They are prescribed. And what's amazing to me is that there's people who are under 10 who are getting diagnosed with type 2 diabetes,
Yes.
which I'm sure you've seen in your practice.
Yes.
So that increase, if once you have that diagnosis, the door should be open to treat you as aggressively as the doctor thinks is wise. And certainly GLP-1s are at the top of their list.
One of the things that we were talking about when we entertained the idea of doing this as a topic on Mind Your Health was the people that we're seeing that parents who are saying, my kid's 10 pounds, she's 12 and she's 10 pounds overweight or 20 pounds overweight. I'm going to get her a GLP-1. And I'm just amazed at the commonplace thought that if I put somebody on a GLP-1, it's magically going to improve their life.
It's not a magic bullet. There are some limitations too. So the weight loss is not specific to just fat. There is actually either a split or maybe even a little more muscle wasting with the weight loss. So that's why in people who are frail already, like the elderly, or people who are not in good health overall, may lose muscle before they lose fat. So that is something to think about. And back to what I was saying about insulin sensitivity, to counteract that, you need to do resistance training.
Okay.
So resistance training can counteract that. It can also help your blood sugar, the diet and exercise piece of that. So resistance training is an important part. And then it can also affect bone mineral density. And so that could be something.
What does that mean?
That means that it can cause issues with your bone hardness and can lead to frailty in your bones, which in someone who's underage who's growing, that could lead to issues. And it certainly leads to issues where people who are elderly or have osteopenia, which is the step before osteoporosis, may tip them into osteoporosis or make them more susceptible to breaking bones.
Whoa.
So this is not benign. It's not benign. So certainly, that's what I said at the beginning. Your doctor needs to be monitoring you. You need to have, the safety precautions and regular, lab work.
I think we stop right there because that is the great takeaway. This is not a benign drug. It needs to be really carefully researched. Talk to your physician. Did I?
Yeah, no. I think where's the best place to go for more information?
So the American Diabetes Association is who writes the guidelines.
Okay.
And I would say that they have some materials that would be for the layperson. There is a guideline that's written for physicians and pharmacists and healthcare providers that's released every 2 years or so. So that's a great place to learn about the thinking behind where these have their place in therapy. And then because they're branded medications, they all have like Wegovy.com and Manjaro.com. Those places are supposed to have educational materials on them as well.
But also, I mean, talk to your local pharmacist.
Absolutely.
I mean, listen to you. They're our go-to for safety and security. I love that. Thank you so much for joining
You're
us.
welcome.
Thank you. Stay with us. There's more to come on Mind Your Health podcast.
Mind your health, mind your health, mind your health, mind your health.